people who are chronically unhoused live half as long as the general public.
Right now, it's 6 people a day dying in Los Angeles.
These are avoidable deaths.
Totally.
I mean, we keep stacking the cards against people and then blaming them for bad, quote unquote, health decisions.
Housing is healthcare. You're a doctor and you're a housing developer. We need more of you.
Some element of housing is healthcare, but you never want the hospital as your landlord. The wait list in Toronto is over 8 years, and many patients will pass away before their name or number is called. What became really clear is that there were 100 patients that made over 4,000 emergency department visits in the last year.
If you could write out a script, go to CVS and get a 1-bedroom apartment, you'd probably do it.
Absolutely. We've seen so many advances in healthcare.
Yeah.
But how many of them are really reaching the people that need it most? Whether it's people living in poverty, people who are unhoused. The physician is the natural attorney for the poor.
We interviewed Dr. Boozary at the Canadian Alliance to End Homelessness. We talk about life, we talk about death, we talk about empathy, we talk about social housing. Dr. Boozary took their parking lot and developed units of social housing. Dr. Boozary is a primary care physician, policymaker, researcher, and the founding executive director of the Gattuso Centre for Social Medicine at the University Health Network in Toronto. This is a powerful, powerful podcast. You're going to want to share it with everyone you know. I want to start by a recent tweet you sent out. Probably remember it because you probably quote this a lot. But you said, housing is a matter of human dignity and sound economics. And then you went into some numbers. Month in a hospital, $30,000. Month in a prison, $12,000. Month in a shelter, $6,000. Month in supportive housing, $4,000.
Yeah, I think the calculus is clear. I mean, I think that the reason sort of I've been putting that out about the human dignity and the health economics. One, I think we probably in this conversation agree that housing is a human right, that I think there's a real human element that we can't really capture. You know, if I see patients who are palliative, who know that they're in the last months of their life, how do you capture the value of someone being able to pass away in a home as opposed to on the street, or be able to bend and will the trajectory of their life the way they want to define health and well-being? I think there's so much richness and resilience in that. I think around the economics, because I'm sure you and I get this question a lot, you know, can we afford housing for all? Can we afford these different solutions? And so when you have those number breakdowns and when you look at the health economics, I mean, my argument back is we can't afford the status quo.
Right. Well, I agree with you, but we're going the opposite direction. As homelessness grows, we're not going in the direction of solutions. We're going in the direction of insanity, right? And that's why I wanted to start with that, because as a medical professional, I mean, you are the expert, you know, to talk about not just your patients, but also how housing is healthcare.
Yeah, and I think it does feel inane with what's happening, right? We have all of this amazing research and evidence, you know, litany of reports that both in the US and Canada that seemingly are gathering dust from policymakers and people making decisions that are more cruel, more costly, and I think really just ultimately punitive to people where there have not been options for health. I mean, this is the other piece that I really push back against is, as a policy researcher, as a physician, the work that I've seen and the data that I've seen, I mean, we keep stacking the cards against people and then blaming them for bad, quote unquote, health decisions.
What do you mean stacking the cards?
I mean, look at the realities of where and what people can do. I mean, I'll speak more locally and directly to the city that I work in Toronto. You have shelter bed capacity every night over 100%. So there are hundreds of calls of people who want to get into shelter, cannot. And this ultimately the argument is, why are people outside? Why are people not going into different settings or trying to get off the quote unquote street? The realities are that there are so few options for people, options for help, options for recovery, options to be able to try to have some stability to rebuild their life. And so we continue to allow these really, and these stacked cards, like let's also be really clear, like start from birth, right? When you look at the structural racism and issues in Canada and the US around differences in life expectancy for Black, Indigenous, and refugee newcomer populations, I mean, they are significant and have been staggering for many, many years. This is not in any way new coming through COVID. And we just had a recent analysis by a group at the university that looked at life expectancy across various parts of the city. And so in one of the more affluent areas, it's about 82 years, sort of the 83, 84 even. In a place where we know, Moss Park, that has high rates of homelessness, it's 12 years less. Right. And so that's not a geography issue. They're 2 kilometers or a mile and a half away. It's about these policy choices that get imposed on people from the time that they're born. And then people say, well, you're not making good health decisions, so you have health outcomes. And I think that's the push of understanding that these are policy choices, policy constraints that are pushed on people. And we then blame them for, things that are just impossible.
Both you and I'm sure, we just met, really. We have empathy, right? I did some research on the amount of times, U.S., I didn't do Canada, thought about it, that death of homeless people or life expectancy was written about in the United States. Because I get so tired of the homeless sector because we're the ones sharing it. It might be only in our echo chamber.
Right.
Sharing, like right now, it's 6 people a day dying in Los Angeles. Last year, it was 5 people a day. The year before, it was 4 people a day. And the only thing that changes is homelessness continues to get worse.
It only gets worse. And I think the point that you make, Mark, is so powerful in the fact that when you look at the data around life expectancy and death, why I push the fact that homelessness is the most powerful social determinant of health is that people who are chronically unhoused live half as long as the general public. Right. So that's across jurisdictions, right? That's Canada, it's US, it's in any jurisdiction that has high rates of homelessness, right? Chronic homelessness, right? So these are people who've been having to be unhoused for not just months, but years. And so that's 30 to 40 birthdays. And to your point, when you push this out of the echo chamber, I mean, the general public will be, would you want to forego half your life or 30 birthdays on no real choice of your own? It becomes real to say, well, wow, that's a staggering health issue. So when we say homelessness is a health crisis, of course it's a health crisis when you've got individuals who are living half as long. And not only are they living half as long, as you have been such a powerful advocate about in telling these stories and showing these stories, is that those life years are also sicker.
And what I believe, never been able to prove it, because we just don't have the funding for the research, the public views homeless people, refugees, immigrants, mostly homeless people, but also people that are suffering from poverty, low income, as less than. When you get to homelessness, they're drug addict criminals. So when you say their life expectancy is less, or that 6 people are dying a day and it's going to be 7 a day in Los Angeles next year, I don't think the public cares. Right?
Well, I mean, that's the hard part to reconcile, but I think it's the part where I think you and I are aligned on why this work is so important.
Well, we can't give up. We got to be screaming the alarm even louder and louder until we can influence the change.
Yeah, and then I think these are the challenges that I think are out there now, is not only in terms of, how do you get people to care, but what are the solutions, right? Because I think part of it is also, look, I think you nailed it. The reality is there's real discrimination against people who live in poverty. Right. And this is centuries. There's definitely decades in the U.S. and Canada. And as you've put out, there's an invisibility. Right. And what I find has come up a lot, especially through COVID and the pandemic, is that there was more visibility. People were not happy to see the rise in encampments, the way that parks were looked at, the way that there was more and more people having to be outside. And I think for a moment, or at least for a period, we were able to mobilize more of a response. But the part that kind of weighs on me as a physician is that it seems like we were only really willing to kind of look at these hotel options and various housing solutions that I'm sure between LA and New York and Toronto came up with communities working with hospitals and cities. And it's a part that I start to think about is that only happened because we were worried, or communities were worried about, neighborhoods were worried about transmissibility? It was about infectious disease. And the idea was, well, we don't want folks who are unhoused in our neighborhood because there's a higher chance that they're going to spread COVID. And we'll do that. But once people feel that, again, there's been pushed to the back of the minds around the pandemic, what do we owe people if it's not actually a pressing threat? To your point, if they're dying, that's something where I think the public has become numb or desensitized to these numbers. To your point, they're only getting worse. And I think that's our real work of how do you cut through the fray of why this is an active choice, and these are preventable deaths. I mean, that's the other piece. These are avoidable deaths.
Totally. You brought up something that the hotel program in California that started because of COVID, people think it's because the politicians cared. But what they cared about was homeless people taking up ICU beds. Because you look at California, you look at Skid Row, and it was really early on in COVID. They thought because they're outside and they're close to each other, that if somebody gets COVID, that it's going to just spread and it's going to take up all the ICU beds for the housed people. So let's get them in hotels. What happened, and nobody knew going into this, is because people are outside and they don't travel as much. Like we go to the grocery store, we go to, maybe get on an airplane, go to church, go to our bowling league, go to wherever, our synagogue, whatever, where homeless people don't travel, so that COVID never spread through the homeless community like originally feared. But the hotel programs continued somewhat, but not so much as a solution.
Correct. Well, and I think those are some really important reflections on that period, because one thing that we saw, I think we have to acknowledge that people who are unhoused deserve a lot of credit for voting with their feet about their survival. When they looked at the realities of, can you survive during especially the first few waves of the pandemic in a setting where you've got bunkers of these beds, and there's the concept of physical distancing was totally impossible. And people did decide to say, look, we're going to take care of each other. We're going to go outside, where it was actually really good infectious disease practice to say we're going to prevent and reduce the rate of spread by being outside wherever possible. So one, I think that's an important piece where we saw COVID rip through shelters, because the same way that there was different travel and people going on cruise ships, you saw shelters with certain dynamics having that same kind of spread. And people decided, we're going to look out for each other and we're going to get out of here and we're going to have to survive. And the other piece, I think, on this, which we really need to be clear about some of the empirical data, there was some research that came out that showed that people who were unhoused were 10 times more likely to die throughout the first 3 waves of COVID.
Wow.
So these were active efforts to try to survive. But on scale, it didn't happen. And yes, you're right. There were certain pockets where there's probably less transmissibility than predicted. But for people who were not able to go outside or did have different vulnerabilities, to your point, we have to be clear that people who are unhoused have far higher rates of these comorbidities that were making them more susceptible to terrible health outcomes from COVID, did succumb to COVID, and at a rate that was 5 to 10 times higher than the general public or people who were housed. And so I think we have these terrible natural experiments and the data that's out there. And how do we start to get the kind of response that isn't just hotel solutions, which, again, were immediate responses, but what are the sustainable solutions that are now to full circle in the conversation? Is it centered in human dignity, but it's also really good health economics?
Well, we started off with kind of like this cost matrix. And, the hotel, as far as cost, is still more expensive than supportive housing, right? Which, from a personal standpoint, having a door and a shower is great, but you don't have a kitchen. Many of these places have horrible rules, almost punitive, like being in prison. People weren't treated with dignity and respect, not able to come and go, not even be able to have family visit, right? You're put in this hotel room and you can't do anything, can't leave, can't move, can't have anybody come visit you.
No, there's no
and
agency.
that's not healthy.
And we heard that in the interviews that we had with people with lived experience of homelessness for Dunhouse, for the work where we've built housing for patients who are unhoused who have high healthcare needs at the University Health Network. Two things really came through. One was, and I hear this from my patients all the time, is when people move into housing, one of the most common things I hear when someone says, "Doc, it's happened," and we have to be clear, the wait list in Toronto is over 8 years. So when we say homelessness is a terminal condition, the weight of the clinical work is knowing that many folks and many patients will pass away before their name or number is called. And so when I do hear and I do see a patient who does get their call into housing, it's a joyous moment, as you know very well. And their celebration piece is usually they start mimicking the sounds of having their own stove of making eggs or anything that they want to cook and prepare for me to come over for lunch or dinner at their home. And so to your point, it's beyond the bed and shower, but that's a really important start point. And the other piece that we heard and that I'm really encouraged by we're able to have at Dunhouse is it being pet friendly.
Yeah.
Right. So these are things that people will not leave their family member, their pets, on the street if they even get the call for housing, and they will make that decision to continue to stay outside.
8-year waiting list. I've always said, when someone gets into housing, the miracle isn't that they got into housing, it's that the system actually worked.
Yeah.
And we've got to fix that.
Yeah. It's just working
Yeah.
far too infrequently.
Yeah.
Right.
Somebody wrote about you in an interview. Housing is healthcare, and where you work, you guys created housing in a parking lot, right?
Right. Yeah. I mean, it's
So your medical facility, right? You're a doctor, a physician, and you're housing developers.
Well, yeah.
That's wild. We need more of you.
Well, yeah, yes and no. I mean, I think we definitely need more housing. I definitely think when I went to medical school in this city, and I never would have thought I would have been in development and architecture and real estate, right? But I think the question is, what would you have us do, right? We talked about the realities of people in front of you who are passing away before they get to quality housing. One of the things that I did when I started the University Health Network is to look at the data and want to really understand, what are the real pressing needs if we're talking about health. And what became really clear is that there were 100 patients that made over 4,000 emergency department visits in the last year because they were getting sicker through homelessness. They had nowhere else to go. And the challenge for the organization is to say, if we are going to really be based in evidence and data as being a health network, not just a healthcare network, we need to be able to try to address these root causes. And so we looked at the space around there was a parking lot. We partnered with the City of Toronto and community and working with Fred Victor in terms of having the nonprofit operator. So I think there's some element of housing is healthcare, but you never want the hospital as your landlord. They're important boundaries and barriers, but I think the reality is you need this coalition to push for these kind of options for people. And so in the coming weeks, 51 people are moving in, many of them who've had, terrible healthcare trajectories. They've been really shut out of the health system, shut out of the social system in many ways. And I think to me, it's just the fundamental start for them to be able to redefine health and well-being.
I think it's amazing. I know Kaiser Permanente in the States has moved in the direction of creating housing. I know in Hollywood they had respite care, and I know they're in other states. To me, it should be a wake-up call if medical professionals are prescribing housing, basically, right? If you could write out a script, go to CVS and get a one-bedroom apartment, you'd probably do it.
Absolutely. And I know that countless physicians and nurse practitioners would be doing that. And I think the reality is we're left to resort to do that because we're not seeing the social systems in place. So that's why I said yes and no. We need more housing. I don't necessarily think healthcare institutions alone are going to be able to fill this gap. But I think you raise a really important point is that when you have, Kaiser, when you have UHN as the largest academic health sciences network in Canada saying, look, we are going to have to address this because there are no other options for
Right.
people, and there are no other sound and viable options for people. My hope, knowing fully well that 51 housing options is not going to solve the homelessness
Right.
crisis in Toronto, but can it offer a push or a playbook for the country, for policymakers at every level? And every level of government did invest in Dunhouse. So it's an example of where you don't need to get in these turf wars. You can have every level of government come together and say, we are aligned on a solution to see it scale across the country. And how do we leverage public land? How do we leverage the expertise of healthcare providers, of communities, of people that have experience to say, what can this housing look like?
Yeah. And you even talked about how cost effective it was, because that's how you got to push it through. Can you talk about that?
Yeah, I mean, I wish we, because these calls, as you know, have been here for years, to your point, from communities, from patient advocates, from healthcare institutions. And I think, how can we align it with where policymakers can make these efforts? And I think it goes back full circle in our conversation. I mean, if you're in the hospital for more than a month with nowhere else, and we're seeing this a lot actually throughout Canada, there is not enough supportive housing options or housing options for people where they're languishing in hospital beds, right? It's not a good scenario for these folks. But here's the other part that I always find fun. When I was here doing my training and across the country, anywhere where sort of years ago, not to date myself, we were going through it, and it probably happens more than we'd like in medicine now, there's some hidden curriculum and some stigma, right? You call the folks who come in frequent flyers to the emergency department, as if anyone wants to be in an emergency department who doesn't need to be, right? Like, I would love for that to be the case, that we've got like great TVs or there's some really nice furniture. Nobody wants to be in the emergency department if they don't feel that they have to be. And the other piece is, we call people who are sort of in beds, bed blockers. And the other part, to your point, is that if a patient is not taking their medications, to your point about how can you even think about that if you don't have the stability about where you're going to sleep this night or next. But here where, you take this fictional pen and you say, okay, I'm going to write in this conversation with Mark. Mark's not taking his medications. Mark is non-compliant with the medication regimen. Not policies have failed Mark driving an early risk of death because he does not know where he's going to be able to sleep tonight. But I have to write that you've been non-compliant or you've not non-adherent with your medication regimen. And so we haven't really been, as a medical profession, willing to call out that these are real system issues, structural issues, and we have to find a way to be clear about what these kind of prescriptions can look like. And so I love to say too that, I could write on my pad housing and hand it to someone who needs it desperately, but you know this more than anyone else. The work for us as healthcare institutions really starts with the humility that we don't have great trust with people who have been unhoused coming into emergency departments or in wards, because there has been real hard treatment, there has been harm, there have been dangers. So how do we also rebuild the healthcare workforce to have community health workers, outreach workers, to be able to reconnect with people as to where they're at? And build these journeys back about saying, we're actually going to be here with you. There's an accompaniment piece that I think, given the strains and pressures on the system, has made that really hard.
There's stigma in the medical profession. There's stigma in every profession.
Right.
I have a friend who is an emergency room physician, and she's often advocating to educate other medical professionals that these are human beings, right? They're not just homeless people. And you're right, there's a distrust. We do a lot of documenting street medicine teams that are going out. And I love going out with street medicine teams.
Absolutely.
It's also the trust issue. A lot of times why they have to go out is because that person has gone to an emergency room or some kind of medical facility. And whatever happened, they lost trust in the system and they don't want to go again. So now they're going to die outside.
Absolutely. And this is the part of where we have to be clear that people don't feel safe in those institutions. The only thing I'd say on this, and you've now taken me down memory lane, being here in Ottawa, which has been some time. But it goes to your point about your colleague wanting to train and teach med students. I will never forget now that on the last day of medical school, there was this class or lecture where you could ask any questions that you had before you went to start residency, right? So you could Ask whatever you felt about, from billing to what it's like to have an independent practice or being a resident to sort of any hacks or tips about going into independence. And one student who was a few rows behind me had asked, do we need to see homeless patients because they don't pay taxes? And that wasn't that long ago, right? We're sitting here. And so, and I actually kind of appreciate that question was to be asked in this sort of safe space of where it is. But these are the stigmas and discrimination towards people who are unhoused. And I mean, it's still, as shocking now as it was then to actually repeat and rethink as to what that thinking was. But these are things that continue to play out as systems. I actually really don't believe that there's bad individuals that want to do this. But if we don't have the systems to be able to say, to your point, we're going to treat and value people with that dignity and equity, you allow for, more and more of the stigma and bias to come into place. And it's not, again, I think everyone who wants to go into healthcare wants to help people. But how do we ensure that we align the structures with actually trying to improve health and well-being, especially for those who are most vulnerable? I think it's moving away from those terms, but also questioning how our training usually puts the onus on the individual or the patient. Yes, we're going to have this codified language and ways that we, have to write as healthcare professionals, but we have to have some of that critique so that we don't get caught in believing this is your failure. No, this is a system failure. This is policy failures. I like to call them moral determinants of health, that these are real issues and questions that we have known the evidence for decades, but our failure to act is a real moral failure, both at the hospital level, at the system level, at the government and policy level. Our hope is that it can shift this away from these are individual and patient failures, as opposed to let's re-examine the choices we're making in terms of where our investments are in people, like we've talked about, for housing at $4,000 a month, as opposed to the hospital for over $30,000.
Earlier, you reminded me of a story. I end all of my talks with two photos of Joseph, who is the first person as an outreach case manager that I helped house. And when Joseph came to us, he had maggots in his leg. He had been outside way too long. So the first thing, of course, we did was take him to the hospital. Of course, he's admitted. And I'm divorced with no goldfish. Hospitals are really lonely places. I got nothing better to do than go visit homeless people that we're working with, right? This is way before permanent supportive housing was a thing. Not way before. I was like right at the infancy, right? So it wasn't like a practice yet. I would visit Joseph and I would, because after they get him better, they're going to exit him back to the streets. Yeah. So I would say, Joseph, whatever you got to do, cough, just, do whatever you got to do. Fake it so you're inside. You got I Love Lucy on the TV. Yeah. You got nurses walking in, taking care of you. Stay here as long as possible. And what was the miracle is a coworker found a loophole in a grant, and we were able to pay for Joseph's apartment. So I was able to drive Joseph from the hospital to his apartment. And the two photos I show, so right after then I got laid off. So I had nothing better to do except go hang out with Joseph. And I took him to Sizzler, which in the States is like a buffet place, cheap steak, probably shoe leather, but yeah. And it was the first steak he's eaten in 13 years. Oh. And he's got this big smile. He's got this massive smile. Then I put up another photo of him eating a hamburger, and he's not smiling. And I said, Joseph, would you smile for me? And he said, no. And I go, why not? He goes, you're not buying me steak. And that is how I end it. But what I don't tell people, because I want people to leave in a good mood, the reason, I'm going to cry. Shit. Didn't plan on this. The reason I end my talks with Joseph is he died in housing. And there's something, people say, well, at least he was housed. If we had gotten him in housing after 6 months or a year, I'm sure his health would be a lot better. But Joseph had no family. So in Los Angeles, if nobody claims the body, they're all buried together in an unmarked grave. And that was too much for me. So I end every one of my talks memorializing Joseph.
Yeah. Well, thank you for sharing that.
Yeah, well, I don't normally share
I appreciate it.
I don't normally share the second piece there. But that's why I end with Joseph. It's a good, nice story with, and it's still a nice story memorializing him, right?
Yeah, I mean, the hard part, we have these unmarked graves, these no-name memorials or unnamed memorials, and I think, it goes back to what you said about how many people are losing every day. That is avoidable and preventable. And I think that's the part that, one, you feel the weight, but I think this is, as you and I get to know each other more and more, I'm sure it'll be clear as what drives you, all the time around. These are preventable diseases or deaths, right? That if someone like Joseph could have been housed 5 years earlier,
right,
what would have his life looked like?
Yeah.
And, that always stays with you. I mean, one of the parts that I struggle with as we are moving people into Dunhouse is 3 people who were identified and were on the list passed away before they'll be able to move in.
Right.
So there's, of course, this joy of having the housing and trying to break some barriers for 51 people. But, it's just we need to be doing more. We need to be doing this earlier. We need to be doing, 10 times as much, twice as fast.
Yeah.
And I think for people who aren't in that work, the reality of realizing just how sick people are in terms of what we're allowing the kind of health conditions for people to live with. Right. It's unconscionable. Yeah. You wouldn't want that for any of your family. You wouldn't want that to be able to say, especially in a country as rich as Canada, a country as rich as the United States, that people are dying from being unhoused. And the other piece, or losing limbs. I don't know what Joseph's outcome was with his feet.
You had to go there. So we were just in Kensington.
Yeah.
Where we visited a shelter where a third of the people have had something amputated.
That's right.
And it's xylazine and tranq, which I'm sure is hitting Toronto.
Yeah.
It's destroying Kensington. And we're doing a news, one of our reporters is doing a series. I wish we had known when we were there doing the documentary because I would have covered it. But she discovered that many of the amputations are actually unnecessary. That medical professionals are, hey, let's push them through the system. Hey, we're just going to cut it off. There's stigma and everything else. So you have 23-year-old kids losing a limb that could have been avoidable. Now, xylazine, all that, fentanyl, we got to stop the inflow of it. Totally, it's unacceptable that horse tranquilizer is growing across the country as a drug that people use to escape pain. We need to treat the person's pain. The problem is what they're trying to escape from. But yes.
Well, no, and I can't comment as much of what's happening, in Kensington, but I will say we've seen from the data in Ontario, where we're sitting now, is that we have some of the most amount of unnecessary amputation because of untreated diabetes.
Wow.
So just think of it from a chronic disease management perspective. I think you raise really important and powerful points around, the toxic drug supply. You look at it from, in medicine, which is bread and butter diabetes management.
Yeah.
You've got people who are having serious and complicated diabetes because they can't continue with their insulin or medication regimen because they either can't afford it or can't continue to keep it.
Yeah.
That they're losing limbs early and often and unnecessarily. And to your point, it goes back to full circle in our conversation. It's not only that people are living half as long. Those life years are really, rife with some sickness from a medical perspective that we wouldn't accept, in the quote unquote general population.
Early on when I started producing television around homelessness, I did a story of an ex-New York City police officer who was on Skid Row with HIV, and the medicine had to be refrigerated, and there's no way to refrigerate. So the story was this person that was bringing him ice every day.
Yeah.
And it was really a feel-good, nice story.
Right.
But you look at, okay, here's a person, and HIV now is very manageable.
Yeah.
And you just need to be able to refrigerate the medicine. If he doesn't refrigerate it, which you can't do when you're homeless.
Well, this is the no-do gap, right? And this isn't that people don't know it, right? The systems, we know these things that can work, or we've seen so many advances in healthcare.
Yeah.
But how many of them are really reaching the people that need it most? And we see this again across, whether it's people living in poverty, people who are unhoused, many of these barriers. And that's the part for me that I think is the thrust of my work, is how do you bridge these gaps? Is it through housing? Is it how do we better deliver primary care services? You made some of the points around street medicine and outreach teams. How do we rebuild trust for people where we continue to see these advances in the hospital and the basic science laboratories, but they're not reaching people, to your point, that could save their lives, that could change the trajectory of their lives. And the fact that we have that knowledge, we have those therapeutics, but we're not delivering them, I think is really the weight.
Well, you said your work, and I probably should have started off asking you what the heck is it that you do, right? But I really wanted to get to the housing and the healthcare. So what is it that you do?
Well, what we've, talked about, right? I think from, my view on it, it's probably where, when I look in walking around Ottawa, where I started my medical career. There was a quote that I read that had always stayed with me, because part of what I want to do, my mother is the most, fair person that I know. It doesn't matter to me, my sibling. If I think I'm a favorite for her, she'll definitely keep me in line and be really honest. And there's a sense of social justice and fairness that was definitely from my mother from birth. And I always wanted to do human rights law, what she wasn't able to do in trying to help work and raise my sister and I. So I was always sort of torn, but I love the clinical aspect. I love the ability in terms of where there was the science. And there was a quote from one of the original social medicine physicians that, impacted one of my mentors, Paul Farmer, but this now goes back hundreds of years, where Virchow had said, the physician is the natural attorney for the poor. And I felt that it finally really clicked for me of what this body of work is about, is how do you, how are you at the intersection of hospital and community, of where there's science and trust, of where you are looking at intersection of social justice to health economics. And that's, the last 10 to 15 years been, the body of work, from whether it's about trying to find fairness in the pharmaceutical industry so folks can know what kind of choices and trust they have with their own provider, to this work around housing, of course, we're seeing it from an impact of the social determinants, to try and ensure we have innovative models of healthcare delivery that actually, to your point, it shouldn't be that innovative that we're talking about mobile care, but these are the realities that we still have in medicine, that if you build it, they will come. Yeah. And as you've seen throughout your career, how do we ensure that we are delivering whatever life-saving intervention, whether it's housing, primary care, food insecurity. We've done some work to try to ensure that, patients and families that can't afford produce, which is becoming more and more in fresh produce and nutritious food, can have that happen, because we know if they're not able to, they're more likely, again, to end up in emergency departments or have bad cardiovascular outcomes. I think that hopefully ties a bit of a thread around some of the work. But as a generalist, again, I never thought I'd be learning about art. I sometimes palm myself off as an architect when we have these conversations around housing. You just have to wear a black turtleneck, and they try to take you seriously. But no, I think this push, I think sometimes we get healthcare has a lane. And my view on this is the lane for me is fundamentally about how we can improve people's lives and their health and well-being. Yeah. And when those policies are creating these roadblocks or these accidents for people, I think it's squarely in our lane in healthcare and in medicine to try to do that work with people that are being most impacted by it.
Yeah. Tell me a good story. Let's end on a good story.
Well, I think there are good ones, I think around one of the patients I just talked to the other day about being able to move into Dunn House, and I think the excitement, and they actually came by to go see it. And as you and I have been in during this conversation, we're in tears. Yeah. And I think, again, the point of it's hard that that's a reality for people, that to have a basic unit has that reaction. But I think that never, I'm sure for you, ever gets old around the reality of, seeing what that impact is for that person, which is more than emergency department visits or hospital readmissions, right? And when I think about, that patient story or a good story, no one has ever come into my office and sort of said, or I've seen the shelter say, Doc, I want to go from 8 emergency department visits this year to 4. And that way I know you'd be a good doctor. They want to see, right? Like, how can you work with them to redefine what their health looks like? And so I think seeing somebody able to come in and say, look, this may now be the start for them, or to have some stability. It's, to me, the most powerful thing I can do in partnership in our practice.
Well, thank you very much for spending some time.
It was great to meet you, and I'm looking forward to more and more of this work.
If you like this podcast or any of our content, documentary films, daily news articles on homelessness, please visit invisiblepeople.tv/donate and give a gift of any size. Our work has never been more important, and we cannot continue without your help.